Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with these lectures, today I am going to discuss mainly on dyspepsia. It is a very broad term. It's mainly a symptom which is very common in your everyday practice. But there will be a lot of things which will be covered under that group, including functional dyspepsia, pathological conditions which produces dyspepsia, and also a group of syndromes which is overlapping, like gastroparesis. Also, there will be other group of disorders which are producing typical symptoms which are presented in a dyspepsia. So it is very confusing, but I'll try to make it as simple as possible. So yes, in this lecture I will be talking mainly on dyspepsia, but little bit on gastroparesis, but I will have a separate video lecture on gastroparesis. Person invariably presents with these two typical pain in epigastric region and fullness, bloating sensation. Those symptoms together, we label that as dyspepsia. We'll be discussing under this common heading: definition or introduction, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complication. Like dizziness, which is a broad term or symptom utilized in neurology, same way dyspepsia is a common term or common symptom which is being presented in upper GI disorders. And there is one more which we call as gastroparesis. So we'll be talking mainly on dyspepsia. So dyspepsia is a stomach disorder. Typically, there is a cluster of symptoms that are classified under a single word we call as a dyspepsia. In a layman word, upset stomach or indigestion. Those type of words are very commonly utilized by a layman. So it is a symptom complex and one of the most common GI tract complaint which any health person will come across in everyday practice. Dyspepsia in a Greek means difficult digestion. May or may not be associated with eating. Means not related to food. That is labeled as dyspepsia. Basically, we divide into two big groups in dyspepsia, that is organic and functional. In organic, we identify some etiology involving upper GI tract, mainly stomach, pancreas, gallbladder, esophagus, any one of those which produces these types of symptoms. While in functional, usually we do not establish the pathophysiology involving stomach and esophagus. Those conditions are excluded. So what are the common symptoms? So it is a group of symptoms consisting only upper abdominal or epigastric pain or discomfort, heartburns, acid regurgitation, belching sensation, bloating sensation, nausea or vomiting. So these are the group of symptoms which are included in a broad term. We call that as a dyspepsia. So some of those symptoms: indigestion, very commonly a layman will utilize that I am having an indigestion to food, bloating sensation, early satiety, nausea, vomiting, epigastric discomfort, fullness, upset stomach, heartburns, that is burning pain in a retrosternal region, stomach ache, queasiness. These are the different way in which the person will present to you. All these symptoms are included in dyspepsia. You can see there is a big list of symptoms, out of which the most common group of symptoms which is present in the patient who describes dyspepsia. So dyspepsia is a polysymptomatic, of which upper abdominal pain is present almost in 35%, heartburn is present in almost 25%, in 13% acid regurgitation, that is reflux, night pains 7%, pain after meals, that is we call postprandial 5%, abdominal bloating 4.2%, then nausea, vomiting, pain aggravated by food, pain relieved by belching, pain relieved by antacids, pain before meals, pain relieved by food, etc., periodic pain, anorexia, all those symptoms. But most common are these four groups of symptoms, that is upper abdominal pain, heartburns, regurgitation, night pains, and pain related to meals. So these are the different symptoms. So we can classify dyspepsia into two big groups, one functional dyspepsia and second organic dyspepsia. Functional is also called non-ulcer dyspepsia, or you can call as an essential dyspepsia or idiopathic dyspepsia. While structural or organic dyspepsia, in that it includes dysmotility-like syndrome, ulcer-like, reflux-like, or structural. And in structural, you can have pancreatobiliary disorders, you can have gastric carcinoma, those particular. So indirectly, we divide into two big groups, functional and organic, or we call non-ulcer, essential, idiopathic in place of a functional, and organic is described as a structural, and in that it may be involvement of stomach, esophagus, pancreatobiliary tree, gastric carcinoma, etc. So basically we have got two types, organic, functional. Inorganic, you can find the reason for the symptoms. 30% of the patient will fall into this category, while 70% of the patient will fall into a functional dyspepsia where you cannot find the cause of dyspepsia by imaging, endoscopy, or even on histology. So now functional dyspepsia will include two big groups depending upon the symptoms. That was put in Rome 4 criteria called Epigastric pain syndrome, short form it is called as a EPS, and second big group postprandial distress syndrome, so that is called PDS. And when both are present together in the same person, then in a broad term it is labeled as a functional dyspepsia, which is we call overlapping, where both groups of symptoms are present, that is epigastric pain syndrome plus postprandial distress syndrome. This is that particular group which falls here. And when you identify the organic pathology, then it is organic dyspepsia. And combined together, functional plus organic, that is dyspepsia together, or we call uninvestigated dyspepsia. So only after investigation you can differentiate into organic and functional dyspepsia. So epigastric pain syndrome, for confirmation you require at least one criteria from these two, that is epigastric pain minimum for more than 3 days in a week, and epigastric burning sensation for more than 3 days in a week. Either of these two, one criteria should be there, and that criteria is producing impact on the life. On investigation there is no organic pathology. this criteria, which is lasting for 3 days in a week, has to be there for more than 3 months. So this criteria should be there for more than 3 months, and symptoms should be more than 6 months duration. Then only you can label a functional dyspepsia, which is of a variety epigastric pain syndrome. While postprandial, you have to have minimum one criteria: postprandial fullness for 1 day in a week, or early satiety for more than 1 day in a week. More than 1 day or equal to 1 day in a week. Either of these two symptoms, postprandial fullness or early satiety. And this produces impact on the life. No organic pathology. Criteria has to be for more than 3 months. So one of these criteria should be there for more than 3 months. And symptoms should be lasting for more than 6 months. So this is a broad term utilized in a dyspepsia, and one of the variety of a dyspepsia is functional dyspepsia, which we come across almost in 70% of the people, and in 30% of the people you might come across a organic pathology. Then we call that as a organic dyspepsia, and that will be only after investigation. If you don't investigate, commonly we put into a very big group uninvestigated dyspepsia, or we call as a dyspepsia group. And then after investigation we rule out organic, and once the organic is ruled out, we put them into a group called as a functional dyspepsia. And functional, then we divide into two big groups: epigastric pain syndrome, postprandial distress syndrome, and overlapping, that is containing both of the symptoms. Means epigastric pain syndromes, so pain syndromes, and we call distress syndrome. So those together, then we call that as overlapping. So functional dyspepsia criteria we already told you: bothersome postprandial fullness, bothersome early satiety. This will be falling into a group what we are already labeled postprandial distress syndrome. And bothersome epigastric pain, bothersome epigastric burning will fall into a group called epigastric pain syndrome. So functional dyspepsia will be consisting of these 4 types of symptoms. You have to have minimum one of the symptoms, and on investigation no evidence of structural disease, particularly on endoscopic examination, which is likely to explain the symptoms. So clinically we do not establish the organic cause, and this criteria should be for last 3 months, and symptoms should be at least lasting for more than 6 months before the diagnosis. These are the criteria which were laid down by Rome 4 diagnostic criteria, and that is together commonly called as a functional dyspepsia. If one of these symptoms is present, postprandial distress syndrome. If one of these symptoms is present, epigastric distress syndrome. And if one from this and one from this is present, then it is overlapping. Functional is also called as idiopathic dyspepsia, essential dyspepsia, non-ulcer dyspepsia, and person can present as a continuous symptoms, intermittent symptoms, or recurrent episodes. The commonest causes together in both, whether it is epigastric pain or it is bloating sensation, what we call as postprandial distress syndrome, so related to food. In both this group, the common causes includes alcohol gastritis, biliary disease, food sensitivity, functional gastroparesis, Helicobacter pylori, hepatitis, hiatus hernia, medications, pancreatic disorders, peptic ulcer disease, etc. Or maybe gastric tumors, referred pain, vascular causes, all this. Now in this particular groups, If you identify the exact pathophysiology on investigation, either by endoscopy or by radiology or by any other investigations, and you establish the exact cause of involvement of the stomach, like gastric ulcer, gastritis, biliary disorders, gastroparesis, then H. pylori gastritis, drug-induced gastritis, peptic ulcer disease, then it is organic cause of dyspepsia. So, organic dyspepsia. Now, these are all the risk factors which will be responsible for dyspepsia, particularly smoking and alcohol, drugs like NSAID, steroids, biphosphonates, cocaine, anti-cancer drugs, all those things. Mental stress accounts for the very big groups. Certain diets, following viral infection, viral gastritis, visceral hypersensitivity. Even there is one condition they describe as autoimmune gastritis, delayed gastric emptying, which is a part of what we call as a gastroparesis, fundal disorders, antrum distension, duodenal sensitivity to an acidic food, duodenal sensitivity to the lipid food, etc. will be, all these factors will be responsible for dyspepsia. And then after investigation, we try to differentiate between the two broad groups in dyspepsia, that is organic group and functional group. Person might have a history of H. pylori infection, anxiety and depression, smoking. Male are more common than female. Then NSAID, history of abuse, mental stress, etc. Now, after the etiology, you identify into three groups. Normally, we use only two words: functional dyspepsia, which is accounting for 70%, or organic dyspepsia, which is accounting for 30%. And in organic, you make a diagnosis after investigation. So we call fully investigated group: GERD, peptic ulcer disease, pancreatic disease, gallstone, gastric carcinoma, etc. But in functional, we call idiopathic. So that will be that group. But there will be one another group, what is called as a non-GI, which can also produce little amount of dyspepsia. That is called non-GI causes for dyspepsia, like cardiac disease, muscular pain, etc. But by and large, we use only two terminology, that is functional and organic dyspepsia or structural dyspepsia. So functional dyspepsia, structural dyspepsia, non-GI causes. So in a structural, non-ulcer dyspepsia, GERD, gastritis, gastric ulcer, duodenal ulcer, pancreatic pathophysiology, gallstones, carcinoma, stress ulcer, all those will be included. So among organic, peptic ulcer disease, GERD, pancreatobiliary disease, ulcer-like dyspepsia, pain is a common, dysmotility, dyspepsia, reflux-like dyspepsia, etc. are the different terms which will be utilized. Means depending upon the type of presentation, ulcer-like, dysmotility-like, and reflux-like dyspepsia. That will be a part of organic dyspepsia. We will not be discussing that in this particular lecture. But divided into three groups: ulcer-like, dysmotility-like, and reflux-like. In reflux-like, GERD, ulcer-like, peptic ulcer disease, and dysmotility-like, gastroparesis. ulcer like dysmotility and reflux. And one more separate group we can put as a pancreatobiliary dyspepsia. Dyspepsia due to carcinoma also. So in organic causes, there is a big list: peptic ulcer, GERD, gastric carcinoma, drug-induced gastroparesis, gallstones, pancreatitis, malabsorption, ischemic bowel disorders, malignancy, and systemic disease like diabetes, thyroid, parathyroid, collagen tissue disorders, all those groups, all those. And we divide into different groups. We divide into three big groups mainly: ulcer-like, dysmotility-like, and reflux-like. And then you can have these two more terminology: pancreatobiliary and carcinoma. And you can see these are the common causes of dyspepsia in organic groups. Organic groups. And when you can't identify the exact etiology, you put them into a group we call as idiopathic. Now, at this stage, I would like to talk little bit regarding what we call the gastroparesis. The etiology of functional dyspepsia and gastroparesis, some good number of times they overlap. And there are some etiology like drugs, post-infection, and another big group, idiopathic. They overlap. While in gastroparesis, mainly it is diabetes mellitus, which is the most common cause for gastroparesis. We'll be discussing in detail when we discuss on gastroparesis. Post-surgical, following a surgery on stomach like partial gastrectomy, gastrojejunostomy, etc. Ischemia, connective tissue disorders, infective disorders, infiltrative disorders, etc. While in case of functional dyspepsia, helicobacterium infection, H. pylori infection, then genetic, then psychological, duodenal inflammation, etc. That will be a part. And in that functional dyspepsia, if you identify the exact etiology, then we call that as organic. If we can't find out the etiology, we put them into a group called as a functional dyspepsia. And if you go through a pathophysiology, there are some things which are overlapping. And when there is an overlapping, good number of time person will have a symptom signs of functional dyspepsia as well as gastroparesis. And that can be delayed gastric emptying, improved gastric accommodation, impaired gastric accommodation, abnormal duodenal feedback, and visceral hypersensitivity, common in both groups, may be overlap. But in functional, more of duodenal inflammation, altered central processing, that is CNS playing a role, and gastric and bile hypersensitivity. While in gastroparesis, antral duodenal dysfunctions, hypofunction of antral part, hypofunction of the fundal part, gastric pacemaker dysrhythmia. There is also one pathophysiology called macrophages dysfunction, and there is a pyloric spasm. There will be a lot of other things which we will be discussing during gastroparesis. So symptoms don't actually accurately reflect underlying pathophysiology or predicts the response to the therapy. Symptom severity does not accurately predict the extent of delay in gastric emptying. That's the reason why good number of time etiology is overlapping as well as pathophysiology is overlapping between functional dyspepsia and gastroparesis. But for diagnosis of gastroparesis, you will require certain studies, what is called gastric emptying study, and then only you can label that as a gastroparesis. Otherwise, symptoms are almost overlapping between both the groups. There is also an overlapping between other groups like GERD, functional dyspepsia, and IBS, irritable bowel syndrome, dyspepsia. Now if you see here, it is almost 34% of the people are overlapping GERD, IBS, and functional dyspepsia. this. Also, there is a overlapping between GRD and functional dyspepsia. There is a overlapping between IBS and functional dyspepsia in 75% of the people. So there is a very big group where you have got overlapping of symptoms of functional dyspepsia and IBS, functional dyspepsia and GRD, and all the three together almost in 35%, 34% of the people. So good number of time it is only after investigation you can differentiate into GRD, IBS or functional dyspepsia. As far as pathophysiology is concerned, there are good number of conditions which will be responsible functional dyspepsia. One, genetic susceptibility. Second, delayed gastric emptying. Now this delayed gastric emptying can be because of visceral hypersensitivity to acid, lipids or distension. Directly it may be responsible. Neurohormonal dysfunction may be also responsible for delayed gastric emptying. H. pylori may be also responsible for that. Indirectly, genetic susceptibility and delayed gastric emptying leads to functional dyspepsia. And if it is proven that there is a delayed gastric emptying more responsible for functional dyspepsia, it will fall into a group called as a gastroparesis. Also, there are other factors which are responsible for delayed gastric emptying as well as directly functional dyspepsia, that is acute GI infection, autonomic dysregulation, CNS dysregulation, psychosocial stress, etc. So this is a simple most slide which explains you functional dyspepsia, and you got more of these symptoms and you diagnose a delayed gastric emptying. This will fall into a group called as a gastroparesis. So CNS responsible, visceral hypersensitivity, inflammatory conditions like H. pylori, virus or allergic gastritis, which is also called as a eosinophilic, decreased fundus accommodation, abnormal distribution of gastric content, over-distended antrum, antrum is over-distended, so it is called hypomobility. Here also there will be hypomobility, then delayed gastric emptying, abnormal myoelectric activity. But both of these group of symptoms will be responsible for either gastroparesis or will be responsible for functional dyspepsia. Even there is a hypothesis of microbiota playing a role in a functional dyspepsia. Visceral hypersensitivity, immune activation, mucosal hyperpermeability, impaired gastric motility, disturbed intestinal secretions, and there are central factors also. And already be proven psychosocial factors, that is anxiety, mental stress, altered vagal output, gastric dysrhythmia, delayed gastric emptying, small intestine having a dysmotility, H. pylori infection, impaired accommodation compliance, visceral hypersensitivity, central or peripheral or vagal responsible for what we call as hypersensitivity, visceral hypersensitivity, all together will produce symptom signs of functional dyspepsia. So all this, delayed gastric emptying, hypersensitivity to gastric distension, impaired accommodation, H. pylori infection, lipid hypersensitivity, acid hypersensitivity, unsuppressed phasic contractility, and atypical non-erosive reflux disease, etc. And opposite, here what symptoms will be produced because of what mechanism. Delayed gastric emptying will produce postprandial fullness, nausea, vomiting. Hypersensitivity will produce epigastric pain, belching, weight loss because of decreased appetite and early satiety. Impaired accommodation will produce early satiety, weight loss. H. pylori will usually produce epigastric pain. Lipid and acid hypersensitivity will produce nausea, and unsuppressed contractility will produce bloating sensation and absence of nausea. Atypical non-erosive will usually be responsible for epigastric pain. These are the pathophysiology. We already mentioned 70% of the time organic dyspepsia, much more common than organic dyspepsia. Almost in 70% of the time, 30% of the time it is organic dyspepsia. And this can be divided into epigastric pain syndrome and distress syndrome. So there are certain groups of symptoms which are very common. Postprandial fullness syndrome will be described as a postprandial distress syndrome, where a regular sized meal irritates the stomach. 90% of the time the person will complain of a postprandial fullness or bloating sensation, early satiety. The best way is tiny meals and lose weight to avoid the symptoms. This group of people will very commonly complain of bloating sensation. While in case of an epigastric pain syndrome, the epigastric pain is quite common. Nausea, early satiety, belching sensation, epigastric burning may be there, and vomiting may be there. So these are the common 8 symptoms which are very, very commonly being described. So burning sensation, bloating sensation, early satiety or early fullness, nausea. Very rarely person might complain of a hematemesis, dark stool, breathlessness, weight loss, epigastric pain, etc. Whenever you get this type of symptoms, this is more in favor of an organic dyspepsia rather than functional dyspepsia. There are some alarming symptoms before you label as a functional. There's a big list like age more than 50 plus new symptoms, upper GI family history of malignancy, weight loss, persistent vomiting, progressive dysphagia, odynophagia, anemia, hematemesis, abdominal mass, lymphadenopathy, iron deficiency anemia, persistent vomiting, and jaundice, etc. So if you want to remember this way, alarm, DES, A for anorexia, L for loss of weight, A for anemia, R for recent onset of persistent symptoms, M for melena and hematemesis, D for dysphagia, E for epigastric mass, and S for suspicious barium meal finding. Whichever way you want to remember, but if you get any one of these symptoms and you are making a diagnosis of functional dyspepsia, it is a red sign, red flag sign. Do investigate again and try to rule out the organic cause which is responsible for those dyspeptic symptoms. So you can have a dyspepsia which overlaps GRD and IBS also. So try to identify, and once the dyspepsia is identified, if it is uninvestigated, then it is put under a label uninvestigated dyspepsia, and after investigation it is separately divided into organic variety or functional variety. In organic, you definitely establish the etiology or pathophysiology for dyspepsia, then we put them into a group called as organic, and if you can't identify the cause, we either call idiopathic or functional. So the most common pathophysiology which is explained under functional dyspepsia is psychological: delayed gastric emptying, impaired gastric accommodation, hypersensitivity to gastric distension, altered duodenal sensitivity to lipids, acid, etc., abnormal intestinal motility, and central nervous system dysfunction. But one group which will also be, you have to keep it in mind, because all this pathophysiology is also playing a role in gastroparesis. So functional dyspepsia, 2 overlapping syndromes, that is, we have got 2, postprandial distress syndrome and epigastric pain syndrome, and you have got an overlapping. If uninvestigated, we put as a common term functional dyspepsia or uninvestigated dyspepsia. Now in Rome 4 criteria, it is already been separated out into two big groups, postprandial distress syndrome and epigastric pain syndrome. Now symptoms of functional dyspepsia can be ulcer-like or dysmotility-like. When it is ulcer-like, epigastric pain syndrome. When it is dysmotility-like, postprandial distress syndrome. So symptoms you can divide into suggestive like GERD, ulcer-like, dysmotility-like, and structural-like symptoms. When structural-like symptoms are present like weight loss, dysphagia, vomiting, bleeding, palpable mass, always rule out organic cause. Same way, GERD-like symptoms, try to rule out suggestion like GERD, so rule out GERD. And these two groups of symptoms, you have to rule out peptic ulcer disease in ulcer-like dyspepsia. And in dysmotility-like dyspepsia, you will have to rule out gastroparesis. So there is a difference between gastroparesis and functional dyspepsia. We will be discussing again in a gastroparesis group. That is, some symptoms are common in both, abdominal pain, early satiety, bloating sensation. But nausea, vomiting, loss of appetite, weight loss and malnutrition are more common in gastroparesis as compared to functional dyspepsia. So indirectly, if a person present with more of nausea, vomiting, more loss of appetite, more weight loss and malnutrition symptoms, always suspect gastroparesis more common than functional dyspepsia. As far as investigation is concerned, you will have to do lot of investigation to rule out mainly organic causes like esophageal manometry, barium swallow, endoscopy, pH monitoring, upper GI endoscopy. You can go for omeprazole challenge test, etc. So common diagnostic investigation between functional and gastroparesis. History and good physical examination is absolutely necessary. Basic laboratory parameter like CBC, very very important, because iron deficiency anemia will be falling into a group where it will be more towards organic groups. Then also we try to rule out pancreatic groups, etc., like amylase, lipase, those particular investigation. Endoscopy will be very very helpful to rule out acid peptic disorders, confirm diagnosis of H. pylori infection, rule out malignancy, inflammatory conditions, celiac disease, eosinophilic gastroenteritis, etc. And then gastric emptying study to rule out gastroparesis group. All these are necessary. And then only if none of these are being established, organic cause is ruled out. Gastric emptying study does not so strongly suggestive of a gastroparesis. It will fall into a group called as a functional dyspepsia. So uninvestigated dyspepsia, either you can start with an empiric therapy. By and large, that is the most common way the person approaches. But along with empiric therapy, you should do a test. That is, proton pump inhibitor and prokinetic drugs are given in an empiric therapy, and person responds dramatically. Almost organic cause is less likely. If still person persists with the symptoms, now you go for endoscopy. If definite cause is established, it is organic dyspepsia, and in that we rule out peptic ulcer, esophagitis, celiac disease, giardiasis, cancer, pancreatitis, biliary disease, etc. And if you establish an H. pylori which is positive, now we have got two possibilities. H. pylori will be positive in both epigastric pain syndrome as well as postprandial distress syndrome. Now if the person is having more of ulcer-like symptoms and epigastric pain symptoms, then give proton pump inhibitor and prokinetic. And if the person has got more of postprandial distress symptoms, then prokinetic will be very, very helpful. And then you can add on acid suppressive therapy indirectly when you combine proton pump inhibitor and prokinetic, and if it is giving a good results, then it is more in favor of functional dyspepsia. And if it does not give good results, always try to rule out organic dyspepsia. And sometimes when it lasts longer, you don't get an adequate response with a prokinetic and acid suppressive disorder, add antidepressants, particularly when you label them as a refractory functional dyspepsia. Then antidepressant, particularly like tryptamine, we call antidepressants. Those should be added, not tryptamine. Sorry. So, uninvestigated dyspepsia for more than 3 months or longer. Exclude the causes of dyspepsia by history, like drugs, etc. And if there are alarming features, go directly for an endoscopy. If there are no alarming features, then you can go for empiric treatment, and you can go for non-invasive test for H. pylori, and then you can give, if H. pylori test is positive, then you can give treatment for H. pylori. And empiric treatment response after 4 weeks. If it is no, then you should go for upper GI endoscopy. If finding explains the symptoms, yes, it is 100% organic dyspepsia, because on upper GI endoscopy, if you get ulcer, inflammation, gastric carcinoma, etc., then it is straightforward organic dyspepsia. If answer is no, then you go for parasites in stool, occult blood, blood chemistry, and you can go for abdominal imaging and gastric emptying studies. If results does not explain the symptoms, it is more in favor of functional dyspepsia. If results explains the symptoms, it is more in favor of organic dyspepsia. So functional dyspepsia, you always try to identify for H. pylori, eradicate that if not done before. Dietary modification. Which are the predominant symptoms? If it is a postprandial fullness, prokinetic drugs with or without PPI. And if it is epigastric pain, proton pump inhibitor is the first drug of choice with or without prokinetic drugs. By and large, both are started together. And if it lasts longer for more than 4 to 8 weeks, then tricyclic antidepressants are the common drug which are being utilized for that what we call as resistance or refractory functional dyspepsia. So that is the way we approach. So functional dyspepsia, same thing mentioned, history, physical examination, alarming symptoms. If it is uninvestigated, go for investigations. If there are other diseases, then try to rule out first H. pylori infections, eradicate by therapy. If symptom resolves, it is in favor of functional dyspepsia. If H. pylori does not resolve, yes, it is H. pylori does not, no response, some symptom resolves, no, go for functional dyspepsia. Yes, H. pylori associated dyspepsia, then you will have to rule out 3 conditions: postprandial distress syndrome, epigastric pain distress syndrome, if it is a functional dyspepsia, and there is an overlapping where there is a combination of 2. And upper GI endoscopy will help to rule out what we call as organic groups. Same thing explained here. If age is less than 60, what you do? If age is more than 60, directly go for what we call as upper GI endoscopy with gastric biopsy. And if it is less, then, and if one alarming symptoms is present, clinically significant weight loss, bleeding, rapidly progressive alarm features, etc., go for endoscopy. rule out H. pylori infection. If it is positive, give the treatment and try to eradicate. If it is negative, consider alternative cause like peptic ulcer disease, dysmotility, hepatic pancreatitis, hepatic disorders, pancreatic disorders or biliary disorders. Try to rule out those causes by different investigation, and if you identify the cause, treat accordingly. But if upper GI endoscopy cause is identifiable, treat the cause. If cause is not identifiable, consider the alternative diagnosis and try to identify those caused by other group of investigation apart from upper GI endoscopy. So approach is always evaluate for organic cause, evaluate for H. pylori infection. If these two are ruled out, always functional dyspepsia is more likely. And again, from treatment part of it, you will be depending upon the clinical presentation. If there is postprandial distress, prokinetic drug is the first drug of choice, followed by proton pump inhibitor. And if it is an epigastric pain, proton pump inhibitor is the first drug of choice, second is prokinetic drugs. So that is the way we approach. Again, same thing is given, explain at your leisure time, you can go through. These are the red flag sign, these are the possible causes, then try to rule out the H. pylori infection, etc. and then approach accordingly. You can go through your at leisure time. So functional dyspepsia treatment is mainly symptomatic treatment. It cannot cure functional dyspepsia. So there is no approved, no FDA approved medications, dietary changes, eradication of H. pylori. There are some drugs which are now there for fundus relaxing drugs like buspirion. Lifestyle modification will include small frequent meals, stop smoking, reduce alcohol, ideally it should be abundant, reduce caffeine, that is tea, coffee, avoid irritating foodstuffs, that is preservatives, then spicy food, fried foods, maintain ideal weight, so maintain your BMI to ideal level, and always look for the medication which can induce GI symptoms like steroids, NSAID, biphosphonates, anti-cancer drugs, certain antibiotics, etc. You can use a prokinetic drugs which will be more beneficial in postprandial distress syndromes, and also look for the drugs which reduces the gastric motility. So prokinetic drugs will be helpful to accelerate the gastric emptying, increase the enteral contraction, decrease the duration of a proximal gastric distension, and they will also help in decreasing nausea, vomiting. Proton pump inhibitor will suppress the acid production, so pain symptoms will be reduced. It will block the gastric acid secretion production and irreversible inhibition of proton pump. So step 1, attempt to establish the specific diagnosis. Step 2, always try to rule out malignancy. Step 3, treat for non-ulcer dyspepsia, that is, do the test for H. pylori and try to eradicate. And you can combine with prokinetic drugs, give the treatment for 1 month and see the response. Endoscopy, if still person is symptomatic, even after giving what we call as an empiric therapy. And last is post endoscopy management if required, depending upon the etiology. So clinical evaluation, always try to rule out organic causes. There are red flag signs, and if there is a red flag sign and age is more than 45, always go for endoscopy. If age is less than 45 and there is no red flag sign, we always call wait and watch, but do watch. So step 1, always rule out by history organic groups. Step 2, you go for endoscopy. Step 3 will be, if person is having age less than 45 and there are no red flag sign, always try to rule out H. pylori infection. If it is positive, if you demonstrate H. pylori infection, then treat accordingly. If success is there, have a follow-up. If it fails, go for endoscopy. And even if the person has got persistent symptom, go for H. pylori and go for endoscopy. If it is negative, give empiric treatment by proton pump inhibitor and prokinetic. If success is there, go for follow-up. This is step 3. And step 4 is, if H. pylori does not give response, or even after treatment for H. pylori or treatment by proton pump inhibitor and prokinetic drugs for minimum 1 month, then you must go for endoscopy. That is step 4. Non-pharmacological therapy is, we usually call as lifestyle modification, like quit smoking, reduce caffeine, particularly tea, coffee, alcohol. You should stop alcohol. Medications like NSAID, aspirin, steroids, biphosphonates, etc. should be avoided depending upon the conditions. Then certain foods which aggravates the acid production should be avoided. Don't eat late, and don't eat and go to the bed immediately. Always eradicate H. pylori properly. So H. pylori treatment should be given by mainly 3 drugs combination, that is proton pump inhibitor, clarithromycin and metronidazole. Combination is most commonly being utilized. Always rule out organic disease and H. pylori, and if it is functional, give proton pump inhibitor with prokinetic for minimum for 4 weeks, and then you can decide either you want to go for H. pylori eradication or endoscopy. Reevaluate if symptom persist. So step 5 is, always try to rule out malignancy. So these are all the different algorithm approach for dyspepsia which we have already discussed before. This is together given in one single slide. At your leisure time you can go through. Again, management wise, first always decide whether it is ulcer like or dysmotility like. If it is postprandial, first preference is prokinetic with proton pump as a second choice, and in ulcer like, proton pump is a first choice followed by prokinetic drugs. Minimum for dysmotility like, this will be the way, and ulcer like, this will be the way you go for. Already we have discussed, so at your leisure time you can go through. This is when it is chronic. Endoscopy is a must. Rule out organic dyspepsia. If it is functional, eradicate H. pylori by proton pump inhibitor and prokinetic. If it is postprandial, prokinetic with proton pump, and if it is pain, then proton pump with prokinetic, depending upon the type. And in a case of refractory, go for antidepressant drugs. This is again same H. pylori. This is for refractory group, tricyclic antidepressant groups. So I end my lecture here. I thank you very much for taking out time. I know that your time is valuable. I appreciate that for spending some of the time with me. Thank you once again. I feel this will be very, very useful to you in your everyday practice, because the most common and broad term which is being described by the person in your everyday practice, and it includes lot of organic causes. Organic causes should be always suspected, and you try to rule out those causes if the symptoms are persistent for a long period. So functional dyspepsia is always diagnosed after full investigation for dyspepsia. When you can't establish the organic causes, then we label that as a functional dyspepsia. And again, in a functional, you should keep it in mind, there is one another terminology which falls into a similar group of symptoms and signs we call as a gastroparesis. Any functional dyspepsia, there are two big groups: epigastric pain syndromes and postprandial distress syndrome, PDS and EPS, and there is an overlapping of both, and plus there is a good number of time overlapping with also either with gastroparesis, or sometimes functional dyspepsia can overlap with IBS or can overlap with GRD. So very confusing, always keep it in mind. Have a patience, take a good history, examine properly, go for a proper investigations, give a proper treatment, and have a proper diagnosis. You will be able to pinpoint the proper etiology for what is the cause of dyspepsia. So I end my lecture here. See you in next lecture on gastroparesis. If you like this lecture, don't forget to press button like. You can share with your friends, and you can give your good suggestions so I can improve and I can have a further future lectures. Do not forget to subscribe also.